It's now recording. First, we will start with GTG, or gestational trophoblastic disease. Okay. First, we will first know what is gestational trophoblastic disease. This, as we know, is a group of disorders like complete and it includes benign and malignant conditions. Benign like complete and incomplete mole, and malignant conditions like invasive mole, choriocarcinoma, placental site trophoblastic tumor. All these are under the GTD, which is a gestational trophoblastic disease. There is another definition, which is gestational trophoblastic neoplasia, which is a persistent GTD. This is usually known when we come after evacuation of molar pregnancy or whatever, and you will find a persistent elevation of beta HCG. When we find a persistent elevation of beta HCG, we first thing that we will come in mind that this is gestational trophoblastic neoplasia. GTD can develop over anything, but also there is reports that neoplastic transformation may occur on atypical placental sites, which will transform to placental site trophoblastic tumor. Okay. The second thing is numbers. We know that numbers are very important. Now there is in the exam we will have only 4% numbers, and this ratio they respected in the last exam. Last July they respected this ratio, that only 4% of questions have numbers. So don't worry much about numbers, just know the most common. You will find that these numbers are frequently repeated. If these numbers are frequently repeated, these are the most common numbers. The incidence of every disease is very important. It may come as question as SPA. This is very important. It is 1 in 714. This is for general population. While for women from Asia, it is more. It is 1 in 387. Yeah, I know these numbers, like it is not a fixed number like we used to get, like 1 in 1,000 or 1 in 100 or whatever. But these numbers, it is somehow complicated. So, and I never saw it come before. Gestational trophoblastic neoplasia, as I said before, it can develop over anything. It can develop after molar pregnancy, non-molar pregnancy, or even after live birth. Non-molar pregnancy, like it can develop after abortion, it can develop after miscarriage, can develop after anything. The incidence after live birth is 1 in 50,000, so it is very rare. It is, yes, very rare. After live birth, we have this one. I will tell you about again in another time, not in this, but you will find, especially if you are reading from patient information leaflets, you will find a table in the beginning of the patient information leaflet. It contains like a common, uncommon, common, rare, very rare, like this. You have to know these numbers. We will discuss again, but at least open any patient information leaflet and read this table. It is in a table. I think its color is pink or something. Okay. It has a very high cure rate, 89 to 100%. 98 to 100%. Very low chemotherapy rate, 5 to 8%. This is overall. While with partial molar pregnancy, chemotherapy is even lower. It is 0.5%. Okay, this is yeah, some sort of comparison between complete mole and partial mole. Complete mole always have diploid number of chromosomes, while partial mole 90% it is triploid, 10% tetraploid or mosaic. With molar pregnancy, with complete mole, you will find that all the chromosomes are androgenic in origin, while in partial mole you will find two sets of paternal and one set of maternal. With complete mole, you will find no evidence of fetal tissue, while with partial mole, you will find evidence of fetal tissue or fetal red blood cells. 75 to 80% of complete mole occur due to duplication of a single sperm following fertilization of an empty ovum. While 20 to 24, this is dispermic fertilization of an empty ovum. So all we have an empty ovum. This most commonly that this ovum will be penetrated by only one sperm. That this sperm will duplicate. While this is the most common. While the other form is that instead of being fertilized by only one sperm, it is fertilized by two sperm. Partial mole, all cases are a dispermic fertilization of a normal ovum. Okay, next we have symptoms and signs of molar pregnancy. The classical features, the very important part is hyperemesis, because this comes a lot in the when it comes like a case, you will find it she have exaggerated pregnancy symptoms, most commonly hyperemesis. So hyperemesis gravidarum is one of the most classic features of molar pregnancy. Also irregular vaginal bleeding, excessive uterine enlargement, and early failed pregnancy. So these patients, if we would make it like a case, you will have patient X. This patient come 6 weeks pregnant. When you examine her, you find her uterus like 12 weeks pregnant. She describes episodes of hyperemesis, and she is coming. Her main complaint today is having vaginal bleeding. So yes, this is a failing pregnancy, but why? You will find also he will give you the beta HCG, and you will find that this one is very elevated. So this is like some sort of a case. It is not actual case, or we will see the cases when we come to solve questions, but you have an idea how it comes. Okay, rarely hyperthyroidism, early onset preeclampsia, abdominal distension due to theca lutein cyst. I think almost always the abdominal distension is due to excessive uterine enlargement. So, but theca lutein cyst, yeah, it may occur. Very rare due to metastatic, coming with signs of metastasis, like acute respiratory failure if the metastasis reaches the lung, or neurological symptoms if it reaches the brain, like seizures or whatever. Okay, how we diagnose? It is very difficult to diagnose it or to differentiate pre-evacuation. Pre-evacuation, you can use ultrasound. Yeah, it will give us an idea. You remember the classical appearance and stormy sunset appearance and honeycomb appearance. These different terms to describe the appearance of GTD. But the definitive diagnosis is made by histological examination. Histological examination, this is the definitive diagnosis. Okay. Majority of histologically proven complete mole were first diagnosed as early delayed miscarriage or an embryonic pregnancy, not as complete mole. So any we should send any products of conception for histopathological examination, because maybe it is mole and we don't know it. The accuracy of pre-evacuation diagnosis, this increased with gestational age. So it is 35 to 40 if before 14 weeks, and 60% if after 14 weeks. Definition or diagnosis of partial mole is more complex, because as we know, partial mole have fetal parts. It will not appear as the classic picture of stormy sunset or the honeycomb appearance. No, you will find fetal tissue, you will find bone, you will find according to the stage you will diagnose it in. So soft you must see multiple soft markers like both cystic spaces in the placenta, and a ratio of transverse to anteroposterior dimension of gestational sac of greater than 1.5 millimeter, I think. No, this is a ratio, sorry, 1.5. This 1.5, this number is important. I think it came before as a question. The transverse to anteroposterior dimension ratio, this came before. It is 1.5. 1.5. You have to know this number. Okay. HCG level may be of value. Yes, because if we find a very high level of beta HCG, yes, this is most probably either twin pregnancy or maybe, but twin pregnancy not that high as in molar pregnancy. Okay. The best method of evacuation is suction curettage. This is for complete mole or even for partial mole, but except if the size of the fetus is small. If the size of the fetus is a part, fetal parts is small, you can use suction evacuation. But if the size of the fetal parts is large, no, you cannot use. You cannot use suction evacuation. Okay. After we do evacuation, we should do urinary pregnancy test after 3 weeks to confirm that we already eliminated every birth and it came back to normal. Sorry. We do it after 3 weeks from any miscarriage. So we make sure that this is not molar pregnancy. Sorry, I'm sorry about this. Anti-D, it's not required for complete mole, but it is required for partial mole. And as we said before, that we cannot differentiate between complete mole and partial mole pre-evacuation. Sometimes it is hard to differentiate. So we will give all cases of molar pregnancy, we'll give them anti-D, unless we are 100% sure that this is complete mole. If we know it is complete mole, okay, you may not give. But if you don't know, if you are not sure, definitely give. Okay. The other part we will discuss again is this last paragraph. Yes, potent oxytocin agents we cannot use because there is a theoretical risk of tumor imply or dissemination of the trophoblastic tissue through the venous system. This is a tumor imply. how to prepare the cervix before evacuation, or is preparing the service for prior to evacuation is a good idea. We can do it, but we can do it immediately before evacuation. But long term, no, we don't use long term or prolonged cervical preparation. Okay, to also this is like oxytocic agent to avoid the tumor envelope. Okay, oxytocic infusion. Uh, Before they said no oxytocin at all can be given, but now no, we can give oxytocin if the patient have severe bleeding, or she requires, or have a tonic postpartum or something. We must give her in this case the risk of the benefit overweighs the risk. So yes, if she is experiencing significant hemorrhage, we can give her oxytocin. Management of persisting gynecological symptoms. She should be consulting with a consultation with a relevant trophoblastic screening center, and also second evacuation may be required if HCG is less than 5,000 units per liter. We may need a second evacuation. What we do is product of conception. We said product of conception must be sent for histopathological examination. Haploid status and immunohistochemistry staining for B57. All these can distinguish between partial and complete mole. If we are doing therapeutic termination, which is abortion, if we are doing abortion and we already 100% sure that this pregnancy, we saw the pregnancy, we saw the fetal parts, we know that this pregnancy was a healthy pregnancy and we need to terminate it for any reason, no need to send this for histopathology, because we already 100% sure that this is a normal pregnancy. But if we do it before even reaching this state, before seeing fetal parts or a heartbeat or this, no, we have to send for histopathology. Okay. Investigation. As we said, a woman who developed resistant vaginal bleeding after evacuation or after pregnancy, any pregnancy, persistent vaginal bleeding after pregnancy should be you should have in mind that this may be GTN. So urine pregnancy test should be done in any case with persistent vaginal bleeding, as this is the most common presentation for GTN, persistent vaginal bleeding, and this came as a question before, the most common presentation of GTN. Or if she developed symptoms from metastasis like dyspnea or abnormal neurology, also she must be investigated for GTN. When we have a twin, one is normal and one is molar. Okay, this was only 4%. And there was no maternal distress from this sorry, from this case. So when you are in a doubt if this is a combined molar with a viable fetus, you should contact the regional fetal medicine unit and relevant trophoblastic screening center. Okay, we will talk again about trophoblastic screening center. This is a center where we should notify them of all cases of GTD and GTN. They must be notified, and I think we have where Yeah, I think yeah, it is in the registry. Yeah, after 2 or 3 slides, we will find it. Who to be notified for the trophoblastic screening center. Okay. When there is one viable and the other pregnancy is mole, so we should she should be counseled about the risk of prenatal morbidity and the outcome of GTN. That for if she want to like if we tell her, okay, you have one normal fetus and one molar pregnancy, some patients will, okay, she will want to take the risk and continue with this pregnancy. We should counsel her about the risks. Okay. Prenatal invasive testing. We will talk about this again, inshallah. Prenatal invasive testing, like amniocentesis or chorionic villus sampling should be obtained to determine whether this is a partial mole or this is a molar pregnancy with coexisting fetal fetus. Okay. The outcome of normal pregnancy with a coexisting complete mole is poor. It is 25% live birth. So why take the risk? Early fetal loss 40%, premature delivery in 36%, pre-eclampsia, it is variable but reported up to 20%. This is the registration I was telling you about. All cases must be registered to the gestational trophoblastic screening center. We should notify them with any case of complete mole, any case of partial mole. No voice. Anyone else having this problem with no voice? Can you hear me? Hello?
Yes, very clear voice.
Yes. Check your
Maybe
yeah.
Internet problem maybe.
Yeah. Check your internet, please. The one who sends a message, oh, she cannot hear. Check. Okay, check. The next is the registration. As I said, complete or partial mole should be notified. Twin, where there is one complete and one or partial hydatiform mole with a coexisting fetus. Limited macroscopic or microscopic molar change suggesting possible partial or early complete molar change. Choriocarcinoma, placental site trophoblastic tumor, atypical placental site nodule. All this should be notified. We should notify the center. Okay. Follow up. Okay, we have here 56 is the number to remember. Sorry. Okay. 56 is the number to remember. This is 56 days. Where is it here? Okay. If the beta HCG have reverted to normal within 56 days of pregnancy, follow-up will be up to 6 months for 6 months from the date of uterine evacuation. And so if it is within first 56 days, only 6 months from the day of evacuation. If not reverted to normal within 56 days, we will follow up for 6 months from normalization of the beta HCG level. And all of them must notify the screening center at the end of any future pregnancy, whatever the outcome of this pregnancy. And beta HCG level must be measured at 6 and 8 weeks, or 6 to 8 weeks after the end of any future pregnancy. But please remember the cut line, which is 56 days. If it is normalized within 56 days, we will follow up for 6 months. But from what? From the termination or from the uterine evacuation. If not normalized within 56 days, we will have to follow up for 6 months from the date of normalization. Okay. Optimum treatment. We could use either single agent or multi-agent chemotherapy. This is according to the FIGO classification or FIGO score. You will find it in the GTG in this. It is a table. Okay. We have parameters, and every parameter will take a score from 0 to 4. The age will only take a score from 0 or 1. If less than 40, it is 0. If 40 or more, it is 1. The type of pregnancy, if it or the antecedent, it is the previous. It is the pregnancy upon which this GTD occurred. If it is mole, this is 0. If abortion, 1. If term, it is 2. Okay, interval months from of index from end of index pregnancy to treatment. How long it took for us to discover this? If it is less than 4 months, from 4 to 7 months, from 7 to 13 or more, or 13 or more. Okay. And pre-treatment serum beta HCG less than 1,000, 1,000 to 10,000, 10,000 to 100,000, or more than 100,000. Largest tumor size, including uterus, less than 3 to 5, more than 5. It is including uterus here because some maybe the largest tumor is a metastatic portion, not just, or we discovered it by metastasis. So the metastasis is the size of the tumor we will be measuring. Okay, site of metastasis, lung, spleen or kidney, gastrointestinal, liver or brain. Number of metastases, 1 to 4, 5 to 8, or more than 8, or no metastasis at all. Previous failed chemotherapy, if single drug, it will take 2. If 2 or more drugs, it will take 4. So according to this, we will score the patient. And chemotherapy, as we said, is incomplete mole. It is 15% and 0.5 for partial mole. Postpartum GTN requiring chemotherapy 1 in 50,000 persons. Okay. According to this score, if the woman take a score of 6 or less, this is a low risk, and this one she will be treated with a single agent chemotherapy, which is intramuscular methotrexate, alternating daily with folinic acid for 1 week, followed by 6 days rest. So she will take, if her score is less than 6, she will take single agent chemotherapy, which is methotrexate. This day we will give her methotrexate. The next day she will take folinic acid. This for 1 week, and 6 days after this she will take rest. Women with a score of more than 7 or more, these are high risk. They should be treated with intravenous multi-agent chemotherapy. Multi-agent chemotherapy, methotrexate, dactinomycin, etoposide, cyclophosphamide, or vincristine. We should make a combination of these. And don't worry, treatment and especially chemotherapy. We are not asking about chemotherapy. We are not asked about chemotherapy because usually it is not us who manage these cases. These cases go for a specialized, so a specialist in gynecological malignancies. So don't worry, just know the names, because it may come as like yes, we can treat it with 1 2 3 4, and he will give you a wrong all of this except, and he will give you a wrong name. So don't worry about the doses, don't worry about the regimens. Just know when it has a score of like this, we will give the like this score of this, we will give like this. And the FIGO score is very important because there is a question in the Strat OG about it, and if it is in the Strat OG, it can come in the exam. Okay, treatment is continued until the BTHCG level return to normal, and then for further 6 consecutive weeks. The cure rate for women with a score less than 6, it is 100%. It is if the score is more than 7, it is 95%. So it has a very high cure rate, and the patient should be. We should assure her that this tumor is treatable, and it has a very good prognosis. Now, placental site trophoblastic tumor is a variant, is considered a variant of gestational trophoblastic neoplasia. And this one should be treated with surgery because it is less sensitive to chemotherapy. Okay, one of the things that she will ask you, when to conceive again, when should I conceive again? First, under no circumstances should she get pregnant before her follow-up is complete. If she is taking chemotherapy, she must wait at least 1 year after completion of treatment. Okay. The age of menopause for women who risk of further molar pregnancy is 1 in 80, and this number is important. More than 98% of women who become pregnant have a risk of having will not have a further molar pregnancy. Okay, so it has a very good prognosis, but she must also notify us, because maybe she is one of the unlucky this 1 in 80, the unlucky one. Okay, if a future molar pregnancy does recur, 68 to 80% will be of the same histological type. The rate of congenital abnormalities 1.8 irrespective of chemotherapy. This is for the if she conceived within this first year. And also the rate of stillbirth was elevated, 18.6 per 1,000. Okay. Long-term outcome. Those who receive chemotherapy, we should tell them that they are at risk of developing earlier menopause. If she has single agent chemotherapy, it will advance by 1 year. If she is taking multi-agent chemotherapy, it will advance by 3 years. If she is taking multi-agent which contain etoposide, they should be advised that they may be at risk of developing secondary cancers. If combination chemotherapy is limited to less than 6 months, there appear to be no increased risk of secondary cancers. All this must be known. Contraception. The contraception of a choice. First, IUD is contraindicated as long as she is under follow-up. The treatment, the contraception of choice is oral contraception, which is or hormonal not oral, hormonal contraception. If she is started to take oral contraception already before the diagnosis is made, let her continue. Don't stop her. Okay, continue. Here the GTG requires her to only start after the normalization, but there is a new paper that came. I think I'll attach it to you on the group. That says that okay, we should start as soon as possible, not just wait for normalization. But as GTG is concerned, she must wait until the normalization. But if she already started, don't stop here. Okay, continue. Okay, hormone replacement therapy. Okay, she can use it, no problem. And this is all with GTD. Now we are going to the second part of our lecture today, which is nausea and vomiting with pregnancy. Okay. What is nausea and vomiting with pregnancy? This is symptoms of nausea and vomiting during early pregnancy where there are no other causes. The incidence of nausea and vomiting is 80%, while hyperemesis gravidarum is 0.3 to 3.6%. Diagnosis: nausea and vomiting should only be diagnosed when onset is in the first trimester of pregnancy and other causes of nausea and vomiting has been excluded. If the initial onset is after 10 plus 6 weeks of gestation, we should investigate our other causes. So nausea, to define it as nausea and vomiting of pregnancy, it must be before 10 plus 6 weeks. It typically starts between the 4th and the 7th week, and it come to a peak at approximately 9th weeks. Then it resolved by 20 weeks in 90% of cases, but in some women it may continue after 20 weeks. Hyperemesis gravidarum. This is protracted nausea and vomiting with a triad of more than 5% pregnancy weight, pre-pregnancy weight loss, dehydration, and electrolyte imbalance. So we cannot say this is hyperemesis gravidarum unless it has this triad. More than 5% pre-pregnancy weight loss, dehydration, and electrolyte imbalance. Classification, we have the PUQE, which is a pregnancy unique quantification of emesis score. This we can use to classify nausea and vomiting, and this is the score. Yeah, this is also from the GTG. I copied it as such. Total score. This is the number of the question she replied. We will ask here some question and she will reply. Every reply we will give a score from 1 to 4 to 5. Sorry, from 1 to 5. Okay. Mild, if the score is 6 or less, it is mild. 7 to 12, this is moderate. 13 to 15, this is severe. Okay. So in the last, we will ask here the first question. In the last 24 hours, for how long have you felt nauseated or sick to your stomach? She will say not at all, 1 hour or less, 2 to 3 hours, 4 hours, more than 6 hours. According to her answer, we will give her a score. The other question we will ask here, in the last 24 hours, have you vomited or thrown up? If she said, yes, I did it once, no, I didn't throw up, this is one. 1 or 2 times, this is two. 2 to 3, this is 3. 5 to 6, it is 4. And 7 or more, it is 5. Here, you should flip it to go with previous. Here, for the first and the last question, he orders them increasingly. Here he orders it decreasingly. So you should flip it so you cannot confuse your mind. In the last 24 hours, how many times have you had reaching or dry heaves without bringing anything up? So no time. 1 to 2, 3 to 4, 5 to 6, 7 or more. This is the same numbers as the same numbers as the question before. If you saw it, yes, it is the same. Almost everyone is the same except for the first one. You will find a small difference. So try to manage. Okay, and there is another one. The BUQE 24 score for this is how many hours have you slept out of 24 hours and why. Maybe she is throwing up by night, and this is have a significant importance for us. On a scale of 0 to 10, how would you rate your well-being? Can you tell me what causes you to feel that way? All these to evaluate her mental status and to evaluate her psychologically, if she would need a psychological support or no. Because if she is not taking, if she is not having enough sleep, if she is not happy with her life, this all may lead to depression, and this is or postpartum depression or postpartum psychosis. This we will be discussing again in another guideline, but these for us to evaluate her mental status. Okay, this is a clinical assessment as whole. This sheet is very important. Also, I took it from the guideline as such. When we are having a clinical assessment, first we have history, examination, investigation. History, history of previous condition, like history of previous nausea and vomiting or hyperemesis. We should also, by history, we should use the BUQE score. And we should, after this, an ability to tolerate food and milk and effect on quality of life, which the 3 questions below the table before. History to exclude other causes like abdominal pain, urinary symptom, infection, drug history, chronic Helicobacter pylori infection, all this from her history. We should have a thorough history with her. Examination, all the vitals should be taken, temperature, pulse, blood pressure. Also oxygen saturation and respiratory rate are required. Here respiratory rate is required because we have electrolyte imbalance. So she may go to respiratory rate may tell us that she is having a massive electrolyte imbalance. Weight, of course, we should weigh her to diagnose hyperemesis gravidarum. Signs of dehydration, also for diagnosis of hyperemesis gravidarum. Signs of muscle wasting, all these are signs of dehydration, and which is also to diagnose hyperemesis gravidarum. Other examination, whatever the history tell us, okay, we will examine for history. Like if she has urinary symptom, okay, let's check her urinary system. If she has infection through throat, she has a chronic infection anywhere, we should investigate, should examine as well. Okay, investigation first, urine dipstick. We should measure ketone bodies, quantify ketonuria. Okay, and midstream urine, very important, because as we said, urinary infection can cause nausea and vomiting. Urea and electrolytes, this is for electrolyte imbalance, hypokalemia or hyperkalemia can occur, both can occur, hypo or hyper. Hyponatremia, dehydration, and renal disease, all these renal disease alone can cause nausea and vomiting. Full blood picture to or full blood count to see infection, anemia, hematocrit, and blood glucose monitoring to exclude diabetic ketoacidosis. If she is diabetic, maybe all this is due to diabetic ketoacidosis. Ultrasound to confirm that the baby is good and viable, and to exclude multiple and trophoblastic disease, because we said before that hyperemesis is a sign of is a classical sign of GTD. In refractory cases or history of previous admission, we will check thyroid function test, liver function test, thyroid function, hypo or hyperthyroidism, liver function test exclude other liver disease like hepatitis, gallstone, and monitor malnutrition as well. Calcium and phosphate, amylase to exclude pancreatitis, ABG to exclude metabolic disturbance to monitor severity. So she have a full workup this case, because this is a serious case. If she got into dehydration, if hyperemesis gravidarum and went to dehydration, we sometimes it may be fatal. Okay, the incidence of hyperemesis gravidarum decrease in the second trimester. In the if in the second pregnancy, so in the second pregnancy, if the paternity is changed, if she choose another, if she married another guy, yes, this can decrease the incidence of hyperemesis gravidarum. It is 10.9. This is the incidence in if the paternity is changed, and if not changed, it is 16%. 2/3 of patients with hyperemesis gravidarum, there may be abnormal thyroid function tests. Liver function tests are abnormal in up to 40% of women with hyperemesis gravidarum, with the most likely abnormality being a rise in the transaminase. Differential diagnosis. All other causes of nausea and vomiting, like peptic ulcer, cholecystitis, gastroenteritis, hepatitis, pancreatitis, genitourinary, like urinary tract infection or pyelonephritis, metabolic condition, neurological condition, drug-induced, any other cause of nausea and vomiting should be excluded before diagnosing this as nausea and vomiting of pregnancy. Okay, severe abdominal or gastric pain. This is not a sign of nausea and vomiting of pregnancy or hyperemesis. And if she has severe abdominal or epigastric pain, no, look for other cause. Chronic infection with Helicobacter also can be a cause, and in this case, Helicobacter pylori treatment should be considered. The initial management, if she has mild nausea and vomiting, she should be managed in community with antiemetic. Okay, go home or go to your home and take antiemetic, or ambulatory daycare if the BQE score is less than 30. ambulatory daycare that she will come in the clinic or in to take like fluids and stuff, and she will go home. She will not be admitted. No, she is coming only for medication and she will go home. All this to minimize the number of admissions. Because as you know, we are here looking for not only the benefit. Yeah, we are looking in the first for the first part for patient safety, but we also are money minded. Like everything you will see that they are referring to cost benefit, cost benefit, cost benefit. So if ambulatory daycare will give us the same result as inpatient, but we will not have to admit, because if she is admitted, she will take a bed, she will take from the resources of the hospital, she will take extra care, and like this. No, if she can be treated and go home, okay, do it. This is more cost beneficial. Inpatient management, consider if continued nausea and vomiting and inability to keep down oral anti-emetic. She cannot be given oral anti-emetic. And there is associated ketonuria or weight loss despite oral anti-emetic. Now she left the nausea and vomiting of pregnancy to be hyperemesis gravidarum. No, hyperemesis gravidarum, this is a serious condition. Okay, no, admit her. Confirmed or suspected comorbidity, other infections that need to be addressed in a hospital. Okay, women who have vomiting but are not dehydrated, like we said, can be managed in community with anti-emetic support, reassurance, oral hydration, and dietary advice. If she is not able to take oral or to take oral fluids, okay, we can use the ambulatory daycare, or we will provide her with parenteral fluid, parental vitamins, and antiemetics, but she will not be admitted. So this is how the initial management go. Therapeutic options. The first therapeutic option is antiemetic, and you will find there's in the back of the guideline, you will find a table with the recommended antiemetic therapy as first line, second line, third line, and everyone with their doses. And I never saw the doses before in the exams, but I saw the names of the what is the first line, what is the second line, what is the third line. But as doses, I never saw it. Maybe it came like, you know, recalls is recalls. Like I always say this, recalls is recalls. So maybe it came, but they didn't remember it. But for me, I haven't seen the doses before. Okay, so and you will find it in a box. I will it is the last slide in this presentation. We will talk about them in the last slide, inshallah. Okay, so first is antiemetic. This is considered first we use one agent. If not responding to single agent, we can use combination. For persistent or severe hyperemesis gravidarum, parental or rectal route can be used, and they are more effective than the oral regimen. They should be asked about previous adverse reaction to antiemetic, like drug-induced extrapyramidal, oculogyric crisis. These can occur with metoclopramide and phenothiazine, so we should ask about them. And as we will see, metoclopramide we don't use as first line. We use it as second line because of the extrapyramidal manifestation, and it is exaggerated with pregnancy. So the first line, use the more familiar drug for you as a first line. You will find that he will give us, I think, 3 options for first line, like cyclazine, prochlorobrazine, promethazine, and chloropromazine. Whatever you feel confident with, give. And metoclopramide is the second line of choice. There is evidence that ondansetron is safe and effective, but because data are limited, also this is a second line. Pyridoxine, which is vitamin B6. This is not recommended, but it is given. I'm telling you, it is not recommended, but it is given, and you will see. You saw it here. Multivitamins and B complex, they give it, but it is not recommended alone. Alone, it is not recommended. Corticosteroids only for severe cases, and if the standard measures have failed. Okay, this will cause dramatic and rapid improvement. We use hydrocortisone, daily intravenous, 300 milligram, and this is superior to metoclopramide. This dose was from a study. The study, they used the daily 300 milligrams hydrocortisone, and it was superior to metoclopramide. And the guidelines suggest the dose that we use is intravenous 100 milligram twice daily. So we use only 200, not the 300. Once the clinical improvement has been achieved, we will switch to oral prednisolone, 40 to 50 milligram per day, and we will taper. We will lower it gradually till the lowest maintenance dose, because you know we cannot withdraw corticosteroid abruptly. Diazepam, not recommended. Okay. Metoclopramide. This is I took this idea from what? Yeah, evidence-based obstetric and gynecology of evidence-based algorithm. It's a very great book, but make sure if you are reading from it that it is a 2016 version. So any guidelines that is updated after 2016, starting from 2016 actually, because this appeared in the last 2000. They didn't include some guidelines that were updated in 2016 as well. So if you are reading from this, make sure that any guidelines that is updated after 2016, that you check check the information and add the new recommendation. And these topics are very good if you are if you want something rapid, but they don't include everything. And I'll talk about this. I'll talk in the after we finish this. I'll talk about the how to study and from where to study. Okay. This is short-term extrapyramidal disorder and tardive dyskinesia. This is the most common adverse effect of this, particularly in young people. It should be only prescribed for a short-term use. Maximum dose of 30 milligram in 24 hours, or 0.5 milligram per kg body weight in 24 hours, whichever is lowest, and the maximum duration of 5 days. Don't give it more than 5 days. And intravenous dose should be administered by slow bolus injection over at least 3 minutes to help minimize the risk. So slow IV infusion, or if it is taken oral, no problem. If it is taking IVs, slow IV, slow bolus injection. And the dose, as I told you, doses is for you, for your practice, but mainly yeah, maybe this dose, because you know you need to need, I don't know, but as I told you, their doses I haven't seen before. Rehydration regimen, normal sign is a regimen of choice, and we will add potassium chloride to the back. We will also, if she is taking rehydration, we will monitor the dairy electrolyte. Okay, dextrose not appropriate unless the serum sodium level are normal and thiamine has been administered. So if you will give dextrose, give thiamine. Keep this as a rule. If you will go give dextrose to any patient, give thiamine with it. Most women admitted to hospital with hyperemesis gravidarum are hyponatremic, hypochloremic, hypokalemic, ketotic. Okay. Dextrose containing solution can precipitate vernix encephalopathy, and we will have a slide on vernix encephalopathy alone. This is in if thiamine is deficient. So if you give dextrose, give thiamine. The dose of thiamine is 100 milligram for each day intravenous dextrose. Complementary therapies like ginger. This is the most complementary therapies that have studies over, and they recommend it. They are telling you that yes, if she don't want oral, if she don't want antiemetic, tell her to take ginger. So ginger tea or ginger biscuit, both are okay with us, and this have a very yeah, this have all the studies tells us this have a good results for mild to moderate nausea and vomiting. The potential adverse effect, anticoagulant, stomach irritation, and potential interaction with beta blocker and benzodiazepine. So if she is using beta blockers or benzodiazepine, no, we will not tell her to take ginger. Aqua stimulations and aquapuncture, aqua pressure, no. Aqua stimulation, okay, safe. Aqua pressure may improve nausea. These both may improve, yes. Aqua stimulation safe. Aqua pressure may improve nausea. So yeah, why not? If it will help, okay, do it. Hypnosis, no, not recommended. Sorry, first, yes, vernix encephalopathy first. Vernix encephalopathy is vitamin B1, which is thiamine deficiency. Clinical picture, blurred vision, unsteadiness, confusion, memory problems, drowsiness. There is no seizures with vernix encephalopathy, and this was a question before. On examination, nystagmus, ophthalmoplegia, hypo or areflexia, gait and or finger nose ataxia, episodic and of slow onset. All this okay, episodic and of slow onset. Potentially fatal, but it is reversible. Complete remission in only 29%. Permanent residual impairment common. Pregnancy loss in 48%. So vernix encephalopathy is a very serious condition, cannot be taken lightly. So if you will give dextrose, give thiamine. Okay, complication. Urea and serum electrolyte levels should be checked daily. For in women required in intravenous fluid, as we said before. Histamine H2 receptor antagonist or proton pump inhibitor for gastroesophageal reflux or esophagitis or gastritis. Thiamine supplementation, as we said, if we are given dextrose, give thiamine. Women admitted with hyperemesis gravidarum, we should offer thromboprophylaxis with a low molecular weight heparin. And thromboprophylaxis have two very important GTGs. Two very important. any patient should be checked for thrombo or a VTE risk in the beginning of pregnancy, at every time she will be admitted to the hospital, and before labor and after birth. She should be checked. All these 4 conditions she should be checked. Any if she developed any condition in pregnancy, should her VTE risk should be assessed. And I'm telling you this because I think yesterday, yesterday I saw in a group, in an Egyptian group for doctor for OB-GYNs, that a doctor, he put this. She was a case that was admitted for. I think she had preterm or something like that. She was admitted for 3 weeks, and after birth she developed leg swelling, and he didn't know what happened or what is the condition. So please, any patients that you will admit, check the risk of VTE. Yes, if she has nausea and vomiting or hyperemesis gravidarum, don't give iron. Don't give iron or any iron-containing supplementation, because iron exaggerates nausea. Enteral and parenteral. If she is able to take fluid, okay. If she is able to take fluid and food, that's good for us. If not, we can use either enteral or parenteral, whatever you are comfortable with, because there is no defined criteria to use or to choose which. Okay, enteral, which is using nasogastric tube, nasoduodenal, nasojejunal, or percutaneous endoscopic gastrostomy or jejunostomy. Parenteral, we will give her IV. So whatever you and your patient is comfortable with, use. We said this before. Termination of pregnancy, all therapeutic measures should have been tried before offering termination. 10% of pregnancy complicated by hyperemesis gravidarum end by termination. Many of these women have not been offered the full range of treatment available, and fewer than 10% had been offered steroids. So they want to decrease this level. So if your patient have hyperemesis gravidarum, give her the full range of treatment before offering her termination. Discharge and follow up, as we do for everything. Individualized management plan should be put. Women with, if she still has symptoms in the late 2nd or 3rd trimester, she should be offered serial scan to monitor fetal growth, because she is in high risk of low birth weight and preterm delivery and low pregnancy, especially if she has low pregnancy weight gain. Ketonuria, she should check ketonuria regularly before to identify the problem. Okay, women with repeated admission, 18% chance of a small for gestational age baby. So that's the importance of serial scan for 2-monitor fetal growth. Future pregnancy, we will tell her that reported recurrence rate of hyperemesis gravidarum is 15.2. Previously, he said 16 previously, but accurate number, it's 15.2. Women with previous hyperemesis gravidarum should be advised that the risk is there is a risk of recurrence, and she should use early lifestyle and dietary modification and anti-emetics. These are good prophylaxis for her. Okay. Effect on quality of life. Of course, her quality of life will be affected, and it will be adversely affected. And mental status should be assessed. And we said before the 3 questions after the BUEQ score, it is for, I'll tell it puke. It's puke. The puke score, it is for assessment of mental health. Okay, this is the treatment algorithm. How we treat? First, initial assessment, and we have a very long table for initial assessment. After initial assessment, you will have a BUEQ score of either 3 to 12, 13 or above, or any score with complication or unsuccessful ambulatory daycare management. If it scores 3 to 12, anti-emetic in community and lifestyle and dietary change. If BUEQ 13 or above, with no complication and not refractory to anti-emetic, also ambulatory daycare until there is ketonuria. Is ambulatory daycare, faster intravenous hydration with normal saline and potassium, anti-emetic and cyanide. If she has any score with complication or unsuccessful ambulatory daycare management, this is inpatient. Inpatient, she will take the same as ambulatory daycare plus thromboprophylaxis, multidisciplinary team approach, and we will consider steroid. This is the recommended anti-emetic therapist. As I said, I told you, he divided it into 3 lines: first, second, third. First line, cyclizine, bromazine, chlorobromazine, this is the first line. Second line, metoclopramide, domperidone, ondansetron. Third line is corticosteroid. Okay, and these are the doses if you want to know them. Now we finished our discussion. We still have 2 points to cover today. Actually 3. The first is how to study, what to study, and what's important. The second point is to continue last week's last week's questions we didn't continue, and to solve this week's questions. But we are going to do only 2 of those. We will solve last week's questions, plus I'll tell you about how to study and from where to study. Okay? But first, I'll end this and I'll share with you other stuff. Okay. First, what to study. What to study? We have GTG, which is Green Top Guideline. We have NICE Guideline. We have PASH, and we have only for HIV we have BHIVA guideline, and you will find also for oncology you will find the NHS guidelines. So it is different from one topic to another. The schedule we put on the group, it is more than enough. It completely covers the aspect and every point, and if there is excess information or another guidelines, I try to look at them and add the extra to the lectures. So don't worry about this. Just study what we put on the group and you will be fine. This is about what to study. And the next point, how to study. For me, I'll share something with you now. Yeah, let's share the hyperemesis guideline. I think you see it now, by now. So this is how I do it. I read the guideline. I highlight the points that I see important. Like, as you see, you will find I'm almost marking point here, point there, point here, point there. This is from my initial reading. The first time I read the guideline, I do this. I just mark the important points. Okay, this is the first step. The second step, I'm using, I don't know if you are familiar with or no, this is, also I'll share. This is Microsoft Office OneNote. I copy the points I marked in the guideline. I copy it to a spreadsheet like this. As you see, this is also the hyperemesis. So I transformed it from, I transferred all the data I want to keep in this spreadsheet. You can do it by hand if you like to write. You can do it on another application. You can do it whatever you want. I just find that OneNote is easy for me. I do it like this, and after I do it like this, I print it. Now I have my initial draft. Like with nausea and vomiting, my initial draft is 4 pages. Yes, it is 3.5, almost 4 pages. I use these 4 pages for my study. When I come to study this or revise, I'll just bring up these 4 pages and I read them 1 time, 2 times, 3 times. And after I read it, I'll go to the question box and start solving questions. Okay, this is how you study. Another point is I study a lot, but I forget. Okay. Okay. Okay, I have to download it. Yes. Uh, this is a curve. This curve, I think it is up for like 30, 40 years now. This is a forgiveness curve. It says, okay, I'll tell you exactly. Yes. As you see here, we have how our minds handle information. Okay, if you read it after we finish, you go home and read, or you are home already, you read what we discussed today. This is the first, you will get the first week. If you didn't revise, if you just took the class, this is the normal line. If you took the class and just go home and never read it again, you will drop by 1 month to less than 10% of what you receive. If you read it after we finish, you will, this is the first review, you will delay this return of the curve. If you reviewed it tomorrow, you will also delay it more. If you read it after 1 week, you will retain 60%, 50 to 60%. If you revised it again after 1 month, you will maintain the level between above 70%. So if you want to your level of level of remember to be higher, don't read it once. Read it once, twice, 3 times, 4 times, and not repeatedly after each other. Not today, tomorrow, the day after tomorrow. No, it is like this. Today, you read it again tomorrow, read it after 1 week, read it after 1 month. You can make your own schedule according to this to read. Now you will only be reading your notes. Don't ever read the guideline in the revision. You will get confused. You will waste your time. For me, I'm telling you, I read it today, I mark what's important. Tomorrow, I'll take what I read today and transfer it to the application I'm using, or to my notes, to the notes I'm taking. And after this, I'll always revise my notes. By time, when you start to solve questions, when you hear from other people and like this, you will get more information. And by time you will see that some of the information you put in your notes are you no longer need them. So you can change your notes, like these 4 pages might come back to 2 to 3. You will cut down, or maybe it will increase to 5 or 6. Keep the your notes between 1 and 6 pages, not more than this. So you copied everything in the guideline. If you took more than 6, unless the guideline is huge, like HIV, 20 pages won't be enough for it. I'm telling you, HIV is very horrible. But it's easy. It's horrible because it contains a lot of information, but all the information are easy. And inshallah, we will be discussing it. So make it like this. Just revise your notes. Revise. Read your notes after you finish. Revise it the second day. Revise it after 1 week, and revise it after 1 month. By this, you will maintain your knowledge. Okay. And all those I saw this this curve from a study blur. Yes, I think it is you know, this an application called Tumblr. Tumblr is where you get inspiration for something. So people are using giving study information, study notes, and study inspiration for you. I entered to before I started study. I entered to see how they study, and all of them were talking about this study curve. You have to revise. You have to revise. Revision is very important. Okay. So this is it. The second point I want to tell you about the books. What books are important, what books are not. If you are looking for something that is easy cut, if you are using if you want a shortcut, use as I told you, obstetric and gynecology evidence-based algorithm. It is a very light book, but as I said, it's not up to date. So keep it up to date. For question books, we have two updated books, which is Andrew. Andrew was updated last year, or this year. Yes, this year. And Calvani, or it is Get Through. Get Through is updated, was updated, I think, the SPA updated last year, and EMQ updated this year. If you are subscribed to the extra material with us, you will get the new version. But sorry, I told you that excess data is only for those subscribed. The excess data are I think my notes and the books, the new books, and also what? Yeah, there will be a mock exam weekly and sorry, weekly and monthly, inshallah. So if you want to subscribe to extra data, you know how to subscribe. Sorry, I'm taking something hot for my throat. Okay. About the question books, I'm telling you, Andrew and Get Through, these are the most recent versions. Okay. The others that you can read for SPA, you have Amanda Jones, we all know it, Mastering, Seema Sharma, Ganesh Gupta, Succeeding, Brian McGowan, all these for SPA. For EMQ, you have P. Senna, you have Get Through, you have Andrea, you have Rika, and you have Succeeding also as EMQ. So I think all of these books can be found in the group, in the section of in the media section. You can find it. If you cannot find it, tell me and I'll share it again and again and again. All of them are there. Okay, this is almost everything you need to know about the exam, the question about the exam. The exam format is 2 papers, like first this part, early pregnancy complications. This is not obstetrics. This is gynecology. This is considered a gynecology part. So you will find it in the gynecology paper. But the papers are not that clear. You will find obstetric questions in gynecology paper, and you will find gynecology questions in obstetric papers. Questions are very long, very, very long. Not long as you will find a long question. No, it contain a lot of information, it will contain a lot of data, so you need to be focused to know what you are looking for. Last exam, they didn't get much from recalls, so I'm telling you recalls is not important, but you can, if you could get it, start if you can put your hand on recalls, read it. I'm not telling you not to read it, okay? So I think this is all. If you need anything of you, or if you want me to repeat this, or if you want specific points on how to study or what to study, please send me on WhatsApp and I'll answer everything. Okay. Now we will continue. Last time we stopped at question number 11. Yes, question number 11. We will start question number 12 now. Okay. So as last time, you can either write your answer or you can open your mic and tell me the answer. Antiphospholipid syndrome is considered the most important treatable cause of a recurrent miscarriage. What percentage of women with recurrent miscarriage have antiphospholipid antibody?
15%.
15%. Dr. Hadia? Yes, exactly, the 15%. Thank you. Okay, the next. Yes, 26 years old woman has had a laparoscopic salpingotomy for ectopic pregnancy. She inquires about the future risk of another ectopic. What is the risk of having subsequent ectopic pregnancy following salpingotomy?
%.
Who is drawing on the? Who is drawing? It's 8%, not 20. Okay. Check your information again, Dr. Sar. Okay. And they were writing it right. Okay, let's clear it so you can draw again. Okay, what is the diagnostic tool? Diagnostic tool for tubal ectopic? Yeah.
Transvaginal ultrasound.
Yeah, everyone is drawing now. Okay, it is transvaginal ultrasound, yes. Okay, what is the proportion of ectopic pregnancy occur in the interstitial portion of the fallopian tube? And please remind me to give you these figures because I didn't include in the lecture. Yeah, everyone is telling 126%. Yes, it is right.
Well,
yes, you are right. Okay, a woman attends for the early pregnancy unit having experienced some discomfort and vaginal bleeding in early pregnancy. It is 6 weeks since her last menstrual period. She is actively trying to conceive. Transvaginal ultrasound scan is performed, but there is no evidence of intrauterine gestational sac. We solved this before, and there is a disagreement about the answer, right? We said that this is failing pregnancy, and she should. Yeah, we said that, but if you, this is not according to the NICE guideline. This is according to something else. I think Dr. Muhammad put it on the group. Recheck the group. Yeah. Yes, this one we solved it before. A woman attends the early pregnancy unit with a small amount of per vaginal spotting. It is 7 weeks since her last menstrual period, but her cycle is irregular. Transvaginal scan is performing, which showed an intrauterine gestational sac measuring 15 millimeter in diameter. Follow-up scan is arranged 14 days later, which show a gestational sac with a diameter of 25. This is transvaginal. Okay. There is now a yolk sac visible with a fetal pool with a crown rump length of 7 millimeter, but no fetal heart rate visible.
This is pregnancy of unknown viability.
Unknown viability.
Unknown viability.
Yes. Cut-off point 25 millimeters of vaginal sac and 7 millimeter.
7 for crown lump length. It is
Yes.
7. Yeah.
7.
Yes, it is 7. So now it is 7.
So, yes.
This is 7.
Not
No,
less than 7. Okay.
it is
Less
7.
than 7. Yes.
Yes, it is 7.
Yes.
This is why I'm telling you, you have to know if the number is with us or no. The cut number is 7. If 7, this is considered miscarriage. So and the second part is he gave you the gestational sac diameter. But we already have a fetal pool. We first look at the fetal pool. If there is a fetal pool, gestational sac diameter, we neglect it, as it is not there. This point, this question tests 2 points. That you know the steps. That first you should look at the fetal pool. First, you should look at the fetal heart. Second, you should look at the fetal pool, and third, you should look at the gestational sac. Okay, this is the this is how it is arranged. Okay. What? Clear. Yes. Okay. What proportion of miscarriage occur after the identification of fetal heart activity?
Less than 5%.
Yes, you are right. This is less than 5%. Okay. 25 years old woman with no live birth attends the recurrent miscarriage clinic. She has had 3 first trimester miscarriages in the past. During consultation, she inquires about her chances of a successful pregnancy when she next become pregnant. Which figure should be quoted? She has previous
60.
40% recurrent miscarriage. 60%
successful.
Yes, you are right. Yes, look, this is how we get
trick.
Yes, how we get tricked. He in the guideline he said the her chance of recurrent miscarriage, but here he wants her pregnancy outcome, successful pregnancy outcome.
Successful.
Yes. So keep your mind on this. What proportion of parents with recurrent miscarriage will be found to have a balanced chromosomal translocation if peripheral blood karyotyping is performed?
2%.
Yes, 2%. And if the product of conception already have translocation, how much? Check it. Check it again. Okay, this is this is EMQ. So as we agreed, we don't. As we agreed before, we don't look at this. We look at the questions first. So yes, this is the first question. 32 years old, attends the miscarriage clinic for follow-up appointment. She had previously been investigated for 3 recurrent first trimesteric loss. All tests according to RCOG guidance are done, but now present with a further pregnancy loss at 16 weeks of gestation.
Product of conception.
Mhm. Thrombophilia, because the second trimesteric.
This is second trimesteric thrombophilia.
And
Great.
okay, and she did all tests according to RCOG guideline. According to RCOG guideline, thrombophilia is not recommended for all cases. So she haven't done thrombophilia screen. She already all tests, including the one you said, the product of conception. This is her fourth pregnancy loss, not third. After third, she did everything except thrombophilia. Now she has it in the second trimester, so thrombophilia screen should be done. Okay. A woman attends a miscarriage clinic after 3 consecutive miscarriages. All investigations are normal. She subsequently has forced pregnancy, which is managed surgically.
This is managed surgically, should be since this is a product of conception for histopathology.
Karyotyping, exactly.
Karyotyping.
Yes. Yes, this is histopathology, karyotyping, product of conception. Okay. Next, 38 years old is referred by her GP to the miscarriage clinic after 2 consecutive miscarriages.
Reassure.
Exactly. She is two miscarriages. We don't have to do anything. No tests
After
required.
3.
Yeah, after 3. This is another question. Okay. 35 years old woman who has had 3 previous cesarean sections, present with a scar pain, vaginal bleeding at 7 weeks. What is the primary diagnostic modality of diagnosing cesarean scar pregnancy? How will you diagnose?
Ultrasound, transvaginal ultrasound, transvaginal.
Yes, we said before that MRI will not give us more information. Transvaginal will give the same information. Okay. 33 years old, and her 4th pregnancy is referred to an obstetric consultant following a late booking scan. It is 16 weeks since her last menstrual period. An ultrasound scan has shown an empty uterus, but a gestational sac outside the uterus, surrounded by lobes of bowel. What diagnostic modality can be useful adjunct in advanced abdominal pregnancy?
MRI.
Yes, because we want to know where is this attached. MRI. Exactly. Okay.
In advance, but in early you can use ultrasound.
Yes.
She did ultrasound already.
Yeah.
Here.
Okay. Here, let me get it back. Okay. She already did ultrasound scan and showed empty, and showed also that so she was diagnosed already. She is diagnosed already by ultrasound.
Yes,
Now
yes.
we need to know where is this attached. So MRI now. Okay.
For management. Yes.
29 years old woman attends the early pregnancy unit following in IVF treatment. She has mild abdominal tenderness, small amount of vaginal bleeding. Her embryo transfer was 5 weeks previously. Her pregnancy test is positive. The patient underwent IVF due to tubal disease secondary to chlamydial infection. what would be the diagnostic tool of a choice for ectopic pregnancy in this situation?
Vaginal ultrasound.
Yes, transvaginal is a choice for ectopic. Any ectopic transvaginal.
Transvaginal.
Yes. Another AMQ. Okay. A woman present to the early pregnancy. Oh, I forgot to tell you one thing. In the exam, this will not be like this. For each of the following scenario, what is the most appropriate management from? No, he will give you a scenario here as well. And above the scenario he will give you a scenario in this. So make sure to read these two lines, these lines that become after the options. Read them before you read the question, so you can have an idea the question is about what. Yes, I forgot to tell you about this. Yes, a woman present to the early pregnancy unit with pain and bleeding at 6 weeks of gestation. Ultrasound scan is performed, which shows empty uterus, barrel-shaped cervix. There is a gestational sac below the level of internal os, with blood flow around the Doppler, around the sac using Doppler. He wants each option. He wants the most appropriate management.
This is cervical
Yes.
ectopic management.
Methotrexate.
Medical management. Cervical.
Methotrexate.
Yes. Yes, we said that with cervical pregnancy, either the mode of choice is the treatment of choice is either conservative or medical, because surgical is associated with a lot of bleeding.
Bleeding.
Yes, so here he chose intramuscular methotrexate, and also inside, but this fetus. Gestation sac below the level, blood flow visible using, but there's also here we can use methotrexate injection inside the sac.
Inside, yes.
Yes, it is another viable option for us. Okay, a woman with a history of left ectopic, managed by salpingotomy, attends the early pregnancy unit with right side pain and vaginal bleeding. It is 7 weeks since her last menstrual period. Transvaginal ultrasound scan demonstrates a mass in the right adnexus, which is tender. Her serum beta HCG level is 7,800. So she has tubal ectopic. Her serum beta HCG level above 5,000. So what will we do?
Surgical management by laparoscopy.
Yes. So laparoscopic.
It is above 5,000. Salpingotomy.
Salpingotomy. Wait. She had previous salpingotomy.
Previous ectopic.
Yeah, salpingotomy in the other tube. So this one, so the other tube is defective. So we will use salpingotomy also for this one.
Yes, because fertility issue for this patient.
Yes, so laparoscopic salpingotomy. A woman with a previous history of ectopic attends the early pregnancy unit for a reassurance scan at 7 weeks of gestation. She has no symptoms. Transvaginal scan show empty uterus, but a 32 millimeter left adnexal cystic mass separate from the ovary. Yolk sac and fetal pool are seen, but there is no fetal heart beat. There is no free fluid. Serum beta HCG is 3,500. This is repeated 48 hours later, and it is 3,800.
Methotrexate.
Methotrexate, yes.
Yes.
Management.
Yeah, we are telling about mangemetry. Yeah, this one also we will use methotrexate. And this is because
It is less than
5,000. Intramuscular methotrexate is the choice they use. And it is all. This is all for today. We will not solve the question about this today's topic. I have like an idea for this, because I want you to read it first, because some of you haven't read it before. Please read it first, revise it, and next time when we come to solve a question, you will have the knowledge in your mind and you can solve it better. Okay, so from now on, every week, every session, we will solve the question of the previous session. Okay, this is okay with you?
Okay.
Okay.
Thank you very much, Amira.
Thank you.